We're setting up this setting up for next quarter, excuse me. The SLN, you can see right here, we'll be emailing it out shortly. Right now we're still picking some speakers, and we'd love anyone's input. If you'd like to email me if you have any great ideas. Otherwise, we're working with med students and nursing students, as well as some of our dental speakers. We're going to try and get us a good lineup for next quarter. Next quarter, we will be moving rooms just over very slightly to T747. Shouldn't be that much of an issue, but if there's an adjustment period, it will be taken care of. Okay, without further ado, today our speaker is Dr. Mark Cadet. He's a dental director at Yakima Valley Farm Workers Clinic. He's going to be talking to you about things going on over in eastern Washington and kind of all over. As you can see here, they do stuff all over Washington, and I actually believe in Oregon a little bit too. You have some of these clinics. So I won't steal his thunder. We'll just switch over to his presentation.
As he said, I'm Mark Cody. I'm the Chief Dental Officer of the Yakima Valley Farm Workers Clinic, and I'm also the Director of the Northwest Dental Residency, and I'll talk a little bit about the residency in the presentation. Now, I'm an old guy. I graduated from Indiana University in 1978, and I've always been grateful to the school because I felt that the school taught me the basics on how to do procedures, how to do clinical dentistry, but one thing it didn't teach was how to deliver that care, and particularly how to deliver that care to low-income populations. So, basically, I'm going to be talking, I've got a lot of slides with a lot of data, and I know we have a short period of time, so I'm going to be skipping over a lot of those slides. I know that the slides are available later, so I thought I'd just include that, so if you ever want to find out a little bit more about the things I'm talking about, you can refer to the data on the slides. But one of the things I do want to say is that in the delivery of healthcare, you know, when you think about it, there are lots of different aspects that you probably aren't aware of. I wasn't aware of. It took me years before I figured out, you know, all the social, economic, and political factors that not only help my profession but also hinder my profession. And these factors are actually having more and more of an effect on dentistry, and I think it's going to have a greater effect on you. It's sort of like the forces of Mordor. They're out there, they're gathering, particularly the issue of access, and it's going to affect you actually a lot more than me. I've seen changes in dentistry in the last 5 years that I haven't seen in the last 35 years. And you know, from the predictions, I'll talk a little bit about this at the end. I think it's just going to gather, and even if you have the idea that you're going to set up an upper end practice in Bellevue, these things are going to affect you. It's going to affect. It's starting off in the health centers now, and it's working its way up. So as I mentioned, I belong to the Yakima Valley Farm Workers Clinic. We're a community health center. I don't know how much you know about health centers, but that's more of a topic than we have time to discuss here. But basically, health centers started in the 70s. Back then, it was kind of a kumbaya type organizations. They were run by people that were really mission-driven. They're still run by people that are mission-driven, but they're much more organized now. In fact, most health centers are highly organized, very efficient deliveries of health care to the poor. And our mission, our vision is the health of one person is the health of humanity. And we're really interested in delivering the health care in an organized and patient-centered health manner. We're a large organization. We're one of the largest in the country. We have 18 medical sites, 10 dental sites. We have 3 mobile medical or dental vans. We have a mental health system, and we have WIC sites. We're just a little bit of everywhere. As you can see, we're down in Oregon. We only have one dental clinic in Oregon at Woodburn, but we're in the process of planning for another one. And before I retire, we'll probably have at least a couple more down in Oregon. Our patients, we have a total of 120,000 some patients. Of those, 40,000 are agricultural workers, and as you can see, almost 14,000 are homeless. So we see the underserved. And the next number of slides I'm going to go through very fast. I just want to let you know what our services are. But we have a full complement of medical services. We have in-clinic pharmacies. We did well over 500,000 prescriptions last year. We have a Ryan White funded HIV/AIDS program, which we do refer those patients in the dental. We try to make sure that they all have dental coverage. We have licensed mental health services. We have community action center, and this is where I think particularly for the homeless, these type of services are very, very critical, because if we can't take care of the social needs of our patients, we aren't going to really be able to take care of the health needs very well either. We have a very large WIC program. Just in Washington alone, we have over 17,000 patients. And with WIC, we have a very organized manner of referring the WIC patients into dental. And it works really well. We have metrics set up where we constantly monitor that, because we want to make sure that the little 1-year-olds get into dental and get a good start in life. We have Children's Village, and I'll show you a couple pictures later on. Children's Village actually, this is the kind of change you can make in public health. Our CEO, about 13, 14 years ago, found out about a story of a migrant farm worker family who had a special needs child. They were referred for specialty services in Seattle. They drove over to Seattle and were actually lost in the city for a couple days. When my boss, Carlos, found out about that, he organized other organizations in Yakima County, and they founded the Children's Village. For medical, we have medical services there, but they also have flyover specialists from Children's Hospital. For dental, we have 2 pediatric dentists, and also it's one of the sites for our pediatric residency program. So we're really proud of that. We have a large staff, over 1,200 members, of which 21 are dentists, and we have 12 dental residents as well. And for dental care, we have 10 dental clinics, total of 95 operatories, 1 dental mobile unit, and we saw almost 73,000 encounters last year. One of the things when I first got to Yakima in 1986, I saw this huge need, and I thought, well, I was the 3rd dentist. We had 2 very rundown clinics, a total of 6 chairs, and fortunately my CEO got there about 6 months before I did. And we began to grow. And every time we grew, we made decisions to grow, I thought, well, if I just had 1 more dentist, I'd take care of the problem in Yakima County. And then again, if I had 1 more dentist, I got that 1 more dentist. I kept thinking if I had another dentist. And it ends up that, as I mentioned, we have lots of dentists now in our system. There are 2 other health centers. There are private dentists that do a lot of care for the underserved in Yakima County. Yet I'll show you in a little bit that 1 more dentist isn't the answer. We still need another dentist, but it's not the answer to solving the healthcare poor. Yakima County is interesting. It's the 2nd largest by size county in Washington. It has the largest population of Hispanics. It's 50% Hispanics. This is actually 2004 data, but I have some more recent data as well. Half of the state's Native American population live in Yakima. That year there were 81,000 migrant seasonal farm workers that some live there full-time, some part-time during the year. Nearly 1 in 3 families live at or below the federal poverty level. And I don't know if you know the federal poverty level, but for a family of 4, I think it's around $23,000. So it's, and housing is, it's high here. It's not quite as high as it is in Seattle, but about 1/3 of their income goes to housing. So it really leaves hardly anything left for food, transportation, and those types of issues. And the unemployment rate, it's down a little bit from that 11.7%. It's higher during the recession. It's starting to come down, but it's still high. And again, for homeless, when you look at who's homeless in Yakima, certainly the severe mentally ill have a higher tendency to be homeless. And there were almost 8,000 of those patients or of that population in Yakima. It's also interesting in Yakima County that, as I mentioned, there's a severe shortage of affordable housing. Nearly half of all available rental units exceeds 30% of the family's monthly income. And they estimated 600 homeless with 4,500 without safe and permanent housing. Now, this was from a report in 2004, and the goal of that report, they actually formed a committee, and they decided that their goal was to get rid of homeless by 2014. Very laudable goal that unfortunately they didn't quite make it, because the last figure I saw was there's probably closer to almost 900 homeless now in Yakima. So I don't know how well you could read that, but it just gives you a little better idea of the age levels of the homeless comparing 2013 and 2014. Cause of the homeless, I'm sure that's probably not a lot different than most places, but the number one cause is the inability to pay rent or mortgage. And it's, as I was reading down the list, it was just interesting to see the effect this has on families. And, when you look at it, a lot of the families are living in, they're living in the bad part of town, certainly not the part I live in. They're living in, 2, sometimes 3 families in single-family homes, and, as you can imagine, the effect that that's going to have on how they're going to be able to take care of their young needs. It actually has a severe impact. Where do the homeless live? Well, in 2014, 266 were in transitional housing. There's emergency shelters, so forth on that one. Out of doors, there were 26 they could track down. And as you probably know, it's hard to get data on homes. So this is, many of these are estimates. And this was interesting. As I was prepared for this, I just wanted to see, well, how many homeless do we actually see in our clinics? And, so look in the Toppenish clinic, 14% of our patients were homeless, which actually surprised me. That was a lot higher than I thought. Because, as you well know, the homeless are not easy to see. We tend, even when they're in front of us, we tend to not see them. So, I can't tell you what the real health status of the homeless is, but I can tell you what it is for the children, because they do smile surveys every state. And with the smile surveys, there's mixed results, which I'll talk about in just a little bit, but the decay rate is fairly high. Decay experience, 3 to 5 year olds, 40%. Untreated decay, 13%. That's actually about average, or maybe a little bit below average from the latest national studies I've seen, but it's pretty comparable. For the third graders, it's still pretty much the same thing. 60%, almost 60% have decay experience in their primary and permanent teeth. Again, you've got to realize that this is a county where we have 6 of our clinics, are in Yakima County. There's another health center with 2 clinics, another health center with 1 clinic, and again, a fairly decent amount of private dentists that are seeing a large portion of these kids, and yet the decay rates are still high. And I'll show a comparison over the past couple of years of that. Who receives the care? Well, it's primarily kids, because Medicaid drives everything, and Medicaid pays well for kids. They don't pay enough for adults for the private dentists to even get their costs. So most of the adult care done by the private dentist is basically done for free. There are special populations in the homeless, and I'll talk about those in a little bit. Dental utilization for Medicaid is pretty interesting. In Yakima, there is, I don't know if you can read that, but it's about 55% access. Medicaid reads access by if one of their medical clients saw a dentist one time, that's access. So, you have to keep that in mind. But national figures for Yakima, or when you compare Yakima with the national figures, when you compare Washington with the national figures, I think we're one of the highest, if not the highest state for Medicaid access. And I think that's primarily due to the ABCD program. It's done, it pays the dentist a much higher rate to see these kids. It's still not the usual customary rate, but at least it's enough where they can actually, have a business, run a business, which is, what you need to be able to see people. That's for kids. Now for adults, it's a little bit different. There's only, it's about 16.4%, about 14% for Yakima for adults. And, as you know, I would guess that most of that care is emergency care. Very few adults in the state are getting routine care that are on Medicaid. And that's because it pays about a third of usual custody fees, and as you know, your costs are going to be far higher than a third of your fees. Utilization and expenditure rates. The main thing I want to point out on this slide is it's rising, and that's something that's important to you because back in 2008 it was 102 million. Back in 2012 it's 167 million. I think the figure now, if I remember right, is closer to 240 million dollars spent in the state for dental. And this is our tax dollars. And if we can't lower the decay rates, this expenditure is going to keep going higher. There's only so much you can get out of taxpayers, and something's going to get. You know, whether it's highways, it's schools, or it's down. You know, you can't just keep having expenditure rises like this and think things are going to be okay. How effective are they? Well, there's actually mixed results on there. The nice thing is that, and this is for Yakima County, compares 2005 to 2010. When you look at the bad news is when you look at the caries experience, I'm not sure if 5% is significant. It might be, but it's not. When you look at how many dentists working on the floor during that period of time has increased from 2005 to 2010, I'm not impressed. Decay rates have dropped, which untreated decay, I should say, has dropped, and I think that's because we have all these dentists doing the care. Rampant decay has unfortunately actually risen a little bit. These surveys aren't perfect, but you know, at least it gives us an idea of where things are. So it's kind of mixed. You know, I think the number of dentists working on these kids is really improving health, but it's really not stopping the actual caries experience much at all. And that's where the big money is going to come into the future. This is a really interesting slide because this comes from the Washington Hospital Association studies. This showed, I clicked part of it. It showed the top 25 primary diagnoses for not dental ER, but for any ER visit in the state of Washington. And as you notice, I think it's what, number 6 is dental disorders. That's for the Medicaid population. So the sixth reason for someone coming to an ER for any ER purposes is for dental. Even more interesting is for the self-pay, those without any insurance at all, it's number 1. So the number 1 reason that they'll go to an ER is for dental. The really bad thing about that, and again, you know, when you look at your pocketbook, the same report showed that this is costing us between $500 and $700. And what do they do in a hospital? You know, for the most part, it's a prescription. You know, extremely expensive prescription that it takes care of the problem, hopefully for so many weeks, then they're back again if they don't get into care. And this is the kind of thing that's just driving costs up, and everybody knows it, but we don't know what to do about it. Or we kind of know what to do about it, but you know, it's hard to get things going. You know, as I mentioned, within the low-income population, there's this group that is just even harder to access. The low-income adults, very difficult. Even with Medicaid, they're so, you know, with the private sector, it doesn't affect this population at all because they can't afford to see these patients. It's not that they're not treating them, but they're treating them in smaller numbers, and they're giving that care away. Nursing homes, that's another black hole in dentistry. No light is shining out of that one. Patients with disabilities, it varies from area to area in the state, but for the most part, these patients aren't getting care. And again, the homeless, that's another population. I'm sure there's others in there, but those were the number 4 ones that I could think of. And so even if you can get a good delivery system going, you still have these pockets of patients that just, you know, even with the best intentions and the best funding, it's still very difficult to reach. So the question is, do we have a failing health delivery system? I would say yes, without any problem at all. But it depends on your perspective. If I'm asked personally, if my healthcare system is failing me, no. I've got good insurance. I can go anywhere I want. The dentists like my insurance. When it doesn't, you know, if the insurance doesn't cover it, I have money to pay. I'm in good shape. Same thing for medical. I have no problems at all. My kids have no problems. I've got them on good insurance. For my patients and for the homeless and for all these other things, it's a failing system. If they're getting spotty care at best, no care at worst. And the decay rates, this is from the CDC 2014 data. These high caries rates. Back in the 90s, I remember reading an article from the director of the CDC saying that he thought caries was going to be a thing of the past, and it's come roaring back. I did see actually a publication today from the ADA that there has been a decrease in decay in the last survey, but the data is too new to really know what's going to happen. So access to care, I don't know how many people have seen Maslow's hierarchy of human needs. I'm not a psychologist. I have no idea if this is really why people can't take care of their teeth. But according to the theory, if you're you have to have the bottom needs taken care of before you can take care of the issues in the top. And so most of our patients are in the bottom two rungs where they're having problems with their health, employment, air, food, not air. Well, actually, clean air. Definitely food, clean water, shelters, all those things. So even though they know flossing is important, even though they know brushing is important, we tell them on a regular basis, it's just hard for them to comprehend what they need to do based on all the other stuff that's affecting them. So in my family, if my kids ended up, they're older now, they ended up decay-free, but if they had decay, that would be on me. But I can't, I've met extremely few bad parents. Most of the parents are good, loving people trying to just get through life. I would say flossing and brushing are probably up in the love and belongings and self-esteem needs, and you've got to have money to get up into that in general. We have a costly healthcare system, $240 million for dental, but $2 billion for overall. This is just in Washington State alone. Those not receiving care, time is getting short, so I'm going to run through these slides fairly quickly. But even if you're on Medicaid, the odds of you getting care, again, as I mentioned, particularly for adults, is not very good. For kids, it's interesting. Yakima County either meets or exceeds even the insurance, kids with good insurance access rates, at least how Medicaid defines access. Dentists are actually in competition to get these kids. So that's how nice the ABCD program has turned things around. They can do it for adults too, but they got to spend money. They have to put the will to allocate the money for it. This just shows that mostly kids are getting the treatment. In 2010, adult dental got dropped off. It came back this past year, but it's going to take a while, to build up. And again, in the private sector, it's tough to get a private dentist to sign up for that, and I don't like it. I think there are clear issues on why they can't do that. I just wanted this slide to show that we're not paying to prevent, and we never have. We're taught to drill and fill. We get paid to drill and fill, and we do a good job of that. We're doing a tremendous amount of fillings in Yakima. We're just not preventing, as you saw in the data, we're not preventing disease at all. And so it just keeps coming back. It's just a horrible problem. Who provides the care? In Yakima County, it's mostly the community health centers, but actually statewide, I believe most of the Medicaid is really done by the private sectors because there's so many more of them. Health centers, though, are coming up, though. They're growing in numbers and in size. I mentioned the Union Gospel Mission. We have a Union Gospel Mission in Yakima. I don't know if you've heard of Dr. Mike Bueller. I think he should be Saint Mike Bueller. He recently retired. He's been working as a volunteer at the Union Gospel Mission. They had a really old rundown clinic for probably 20-some years. He retired. His idea of retirement is to get the money to build a brand new facility, which he did. And so it's a modern 4-chair dental clinic, beautiful clinic. He has a fee scale, which even if patients can't afford it, he makes them, or he has them sign up for charity or for volunteer efforts to, clean up the mission, those type of things. And they're getting a lot of care done. He works with us in our residency program. He does the implant training, and so we decided, we talked it over, and so we established Union Gospel Mission as a residence, one of our residency sites. So not only do they have volunteer dentists who come in, but they have a resident working, so we get to double the amount of work with no cost because we get the resident federal grants. It was just a really nice combination. The resident gets an absolute wealth of dental experiences there. Volunteer programs are hard, though. They're hard to run. basically, the reason that Union Gospel Mission is so successful is Mike Diller. He is the driving force. He goes on mission trips around the world. That's the kind of guy he is. And with the volunteers, if you don't have that leader with the right charisma, it's really tough to get volunteers because, as you know, the industry's hard. And you work the full week, and even if you want to volunteer, you want to do the same thing. And, that's how a lot of people feel. Funding is always hard to find. Even with Medicaid, a lot of these patients now are eligible for Medicaid, but if a volunteer comes in that's not signed up for Medicaid, that treatment that he does, even though Dr. Bueller is signed up for Medicaid, they can't charge Medicaid for it. So a lot of care is on a sliding fee scale, which means they don't get enough money to really run the service, so a lot of donations are made. Scheduling is always difficult with volunteers coming in and out because, as you know, volunteers, something else will come up, and even when they're really geared up, they won't always make it like they would make a regular clinic schedule. Multiple providers following up one treatment plan, that it can be difficult, and just plain burnout. Everybody is busy, and whether it's with your practice, with your kids, with church activity, whatever, everybody's busy, and it's really easy to get burned out. So volunteer programs are absolutely unbelievable. I'm just amazed at how many there are, how successful they are, and they're hard to run. Delivery of healthcare services in Yakima County, I mentioned this before, primarily Medicaid, with the private sector, mostly with kids. The rest is free. Public health clinics, there are community health centers, the Indian Health Service, there are free clinics, health district clinics, there's quite a few around there. I'm going to skip over some of this a little bit. Public health really, what I do is community health, it's not public health. And the reason it's not public health is that my job is to run an efficient, cost-effective practice. And we do. I have some of my dentists doing over $1 million in gross production a year. We've got a system that really works. My job is also to the best of my ability, ensure that we have quality practice. I do the practice parameters. We have sliding fee scales and in some cases free care when the patient can't afford anything. But we do, that's about 90% of my job. There is another department in my health center that really does public health dentistry, and that's our community. We have a very active community sealing program, and we have preventative services in medical. We're getting more and more of our physicians to pay for it, going to show those health fairs, access to priorities. These are the things that health education and health promotion, trying to turn people around. Dental residencies. So, I don't know if you know the Landy model, but the Landy model is shown by research that to train residents in rural areas, the odds are much higher that they'll come back to practice in rural areas. And that's what the Northwest Dental Residency is based on. I don't know if you all have gotten our brochures, but we have them here for you if you're interested at all. We have positions open too if you're interested. I'll give you an example of most of our residents, actually I think it's about 70%, go on and do either private practice, do care for the underserved, or go into community health centers. 20% of our dentists now are former residents. I'll give you an example of our pediatric residency program. This started at the University of Washington because during the recession, funds were got cut, and we had to, it ended up the University of Washington was not able to fund that anymore. We found funding with the Lutheran Medical Center, so basically it's the same residency, just a different sponsor now. But when we started the pediatric residency, there were no pediatric dentists at all in Yakima County. As a direct result of the residency, 2 of our faculty eventually went to private practice. 2 of our residents established private practice. So 4 private pediatric dentists, 4 of our own pediatric dentists within my system, and 6 pediatric dental residents. So a total of 14 pediatric dentists practicing in the county because of one residency program. 2 of them went to Wenatchee and helped increase the pediatric population there. So it's, residencies can work, and I think it's a great example of how we can increase access. Not only me, but there's a number of people in the state that are starting to think, should we see if we can develop a statewide dental residency network and look at areas that really need the care. I think it's a lot better than mid-level proposals that are currently being seem to get into legislative attention every year. The Northwest Dental Residency began in 2006. We have, it is an AG program. As I mentioned, we have one of our sites at the New Gospel Mission. We're in Yakima, Grandview, Toppenish, we're up in Wenatchee, and Chelan. We also work with the Lutheran Medical Center for their HD program. We have sites in Spokane and Walla. I'm also very proud of the fact that we've worked with the University of Washington for years, starting back in 1989, with dental students coming over to our program. And in the early 90s, the University of Washington came to the Yakima Valley and worked with our program. We ended up publishing the first fluoride varnish study in the United States. I'm really proud of that, although I have to admit it had been published in Europe for 20 years before us, but it was still, and I believe Washington was one of the first states they used that data from these early studies to include Medicaid, to include the payment for a varnish through Medicaid. And originally it wasn't paid for by Medicaid. And since then, I know North Carolina is another very early starter, and I believe pretty much every state in the country does that. So if you're thinking, it's amazing what can be done working in community health, particularly partner with the right people at the university. This is what really the residencies are all about. I mean, we see some very interesting things, and we get to work on a lot of things that you may or may not see in dental school. I'm not sure, it's been a while since I've been to school. We're sponsored, the main sponsor is my program, Yakima Valley Farmers Clinic. We're co-sponsored by the University of Washington Dental School. Very happy about that. They're extremely helpful about our program. You already mentioned our sites. Time's getting short, so I won't mention all our program goals. And basically what we want to do is, in many ways, it's an apprenticeship to the extent that it takes a brand new graduated dental school and prepares them for the practice of dentistry. And you get to do a lot more endo and all these other services that you, some of you may not get a chance to do a lot of while you're in school. We have actually, there are dental schools that they're graduating without having done any more endo at all. So it's really nice to have this available, not in our program, but also other residencies around the state of Texas. I'll skip over this. Most of this is brochure. Because we're a health center, don't think we don't have modern equipment. We just bought 3D digital impressions that the residents are now using this year. We have a very proud of our dental electronic record, a very sophisticated one. We have clinical microscopes we can use for endodontics, scopes, soft tissue lasers. So we try to assure each year, we try to make it where we need to go with equipment to make sure that we have the kind of things that residents would want to practice on and get used to using. Our facilities are beautiful. This is the Children's Village facility, and this is where these special needs kids come in and they see this. We try to make it a really fun atmosphere for them. And these are just where our different sites are, this outdoor shots of the buildings. Actually, Bob Dylan was one of my favorite songwriters back in the 60s, and I don't know if you ever heard the song, The Times They Are Changing, but you got to listen to it because it's a great song. They talked about the changes going on in the 60s, actually tremendous social changes. Well, now, change really is coming to dentistry. And I think I mentioned before, I see more change in the past 5 years than the past 35 years. There were no corporate practices in Yakima, I think probably 5 or 6 years ago, quite a few now. The Affordable Care Act is changing everything. Of course, everybody knows there's an issue in the Supreme Court, and who knows where it's going to go right now. But if it stays, when you think about it, all the kids, in one way or another, are under the federal Affordable Care Act, and the federal government has at least their hands in it. Even though it's through private, many of these through the insurance exchanges, they have their hands in it. And really, what this means is a lot of things. The government starts off with Medicare. Where Medicare goes, typically Medicaid goes. And where Medicaid goes, typically the insurance companies will go. Credentialing was I never heard of credentialing until, it's been actually quite a while in our health center, but now, I looked up credentialing the other day, and all these insurance plans are requiring new dentists to be credentialed. I mean, it's a 30 and 40 page information sheet that you have to sign up for insurance plan. But with Medicare right now, is they're shifting to a value-based reimbursement. So this will come to Medicaid, and when you look at it, the state of Washington just passed, I think, 54 measures that they're going to start having the insurance exchanges measure. There's one dental measure on there, it's already garnished down in the medical plans. It'll take a while before that'll become effective, but eventually, most of the physicians in the state of Washington they'll be encouraged to paint fluoride varnish on it. Personally, I think this is a good thing, but what's going to come down is they're also going to look at other dental measures that we can do, the dentists will really be, again, encouraged to do, and usually encouragement means they'll be incentivized or de-incentivized depending on what their scores are. Right now, there's a proliferation of public insurance exchanges, and what does that mean? Well, a lot of insurance right now is covered by companies. So go to a company, they got great insurance. Well, because of the Affordable Care Act, the people that, I've been to different presentations with people far smarter than me, and what they're saying is that they believe that more and more insurance is going to be offered by private plans, meaning that instead of you getting insurance plans from your, say like with me, with my company, I'll have to go out and shop for my own. Now, what they're finding out is that when patients shop for their own insurance, they shop for the HDHPs, which are the high deductible health plans. That means they're going for cost. They're assuming quality. They're looking for cost. And that's happening in medical. Eventually, it's probably going to happen in dental. I have a hard time thinking that, we're going to have to display our fees on our websites, but after this one conference I went to, I came back, and the first thing I saw was a letter to the editor of a lady complaining about her dentist won't tell her fees, and she wants to know what her fees are. And so all this stuff is happening. It's just amazing how rapid the change. There's going to be a greater patient control or treatment plan decisions. In the past, when I graduated, if you went to private practice and you said, Mrs. Smith, you need such, generally they'd say, okay. Now, they're going to argue with you, and it's going to be on cost. There's also going to be an increase in online rating systems. You've already seen that already, and I think it's only going to get more and more, this is a growing trend. Greater medical dental integration, this is really good. It's happening. Here, patient-centered medical home. I prefer patient-centered health home because it includes dental, medical, and mental health. The metrification of dentistry drives me crazy, but it's also a great thing. What I mean by that is that everything now, even private practice is run by metrics. If you can't measure something, you can't change it. So, right now, a lot of dentists are tracking their recalls, they're tracking their productivity, all this kind of thing. Well, now everybody's getting, at least in the health centers, are getting into quality metrics. What that means for dentistry, who knows, because dentistry hasn't really done a great job of defining what those quality metrics are going to be. But as those get defined, again, dentists are going to be held by these quality metrics. Hopefully they're going to be good ones. You probably already know this, the solo practitioner, that was king when I graduated. I think you're going to see more and more group practices because of costs and regulations related to practice. When you look at just the cost to figure out how to take care of HIPAA issues and infection control, unbelievable. And so it's going to be harder and harder for one dentist to figure all this out and pay for it and have the expertise brought in to set their offices up right. But again, that's not a bad thing. Group practice is great. Solo practices are hard. Changes in community health centers, we're seeing those right now. Crushing regulations just to give you an example, HIPAA, to me it's a sledgehammer to swat a flea. There is a critical problem out there, but everything that happens now, the first question is how is this going to affect HIPAA? And everything has to be studied in our health center before we can even put simple software in. Of course, before we just pushed a button, now our ICE department has to get involved. And again, I think we're just seeing the beginning of all this stuff, and eventually it's going to get everybody. The first dentist in the United States got fined for a HIPAA violation in Indiana. I just saw that on the news this week. More accountability to funders. I'm not saying more accountability to our patients, more accountability to funders, and that's a thing in the future. Not to get you too depressed, though. When I graduated, it was, the news was dismal. There were too many dentists out there, more and more dentists were in the pipeline. Expanded duties, now, assistants able to take alginate impressions and able to do croquis and that stuff, it's common. Well, back then it was unheard of. And expanded duties assistants were just coming on board back then, and everybody was in uproar. I was told, along with my fellow classmates, that the golden age of dentistry was over. It came roaring back. If it ended, it came roaring back. And I think with the best advice I can give you on this is to read a lot, figure out where the trends are, because there is tremendous change happening. Change is risky, but with change, there's also tremendous opportunity, and that's what we're seeing in the health centers. We're going after where the opportunities are, and I think you'll find that too. That if you're smart, you figure out how things are going to go, you're going to be in good shape. If you think you're going to have a practice of the dentist in the 1970s, good luck. I wish you luck, and you may get there, but it's going to be a lot more difficult than it was when I came. So that's it. If you have any questions, if you have any interest in the residency at all, let me know, and I'd be more than happy to give you more information. My number, you can give my number now, or it's in the social, or if you ever want to know anything about health science, let me know.
Here are the brochures for the residency, if anybody is interested here. And
Come down and get these brochures. Don't forget to fill out the evaluations, and then also sign in for those of you who are late. Don't forget to log your hours and do any makeup assignments that need done. Okay, thanks everyone for a great course. Oh, and eat pizza. Come on, some left.